Welcome delegates. On behalf of Organizing Committee of Bengal Liver Summit Midterm Inazal Meeting held at January 2026, I bring greetings from PGI Chandigarh. My name is Dr. Nipun Verma and I am going to speak on a debrief session on hepatic encephalopathy led by international experts during the meeting. In this session, we moved to discuss most complex syndrome in the hepatology related to hepatic encephalopathy, and the discussions were Professor Jasmohan Bajaj, Professor Elliot Tapper, Professor Shalimar, Professor Rahul, Professor B.C. Sharma. So the sessions included discussions on minimal hepatic encephalopathy. This was beautifully discussed by Dr. Bajaj. He discussed when to diagnose minimal hepatic encephalopathy in patients with cirrhosis, in patients who have poor quality of life, poor driving skills, perturbed sleep. These are the group of patients with cirrhosis where minimal hepatic encephalopathy screening should be done, because it is linked to progression to overt hepatic encephalopathy, recurrent hospitalizations and mortality. So, we discussed several and nuanced approaches which included animal naming test and several bedside tests which he has developed in-house and validated across several centers in US. So, he showed that a special attention to these patients, treating them with lactulose or rifaximin, we can prevent the recurrence and progression to overt hepatic encephalopathy and improvement in quality of life and driving skills, which ultimately improves this saving the lives as well as the cost. Then there was a interesting debate on role of ammonia in patients with cirrhosis. So for the motion, Professor Rahul discussed elegantly where ammonia needs to be tested in patients with cirrhosis. The key take home was it should be used as an adjunct to clinical assessments, and in patients where there is a diagnostic uncertainty, ammonia can be used to rule out the alternative causes of hepatic encephalopathy or encephalopathy in a patient who is admitted in hospital. Several nuances in testing, the technical errors, the variability of sampling, the food, the nutrition, and several aspects of ammonia were discussed, and Dr. Shalimar opposed by saying that ammonia is not a routine biomarker, should not be done in all patients, and why it should not be done. He discussed that the literature as of today is small, scattered, heterogeneous, and robust studies are therefore needed to actually see the utility of ammonia in patients who are admitted in hospital. Not all patients who are admitted with encephalopathy with cirrhosis in hospital have hepatic encephalopathy. Several other causes such as intracranial bleed, infections, meningitis, encephalitis were discussed, and how to diagnose them in the background of hepatic encephalopathy was discussed. Professor B.C. Sharma discussed elegantly the use of L-ornithine L-aspartate in patients with hepatic encephalopathy. He mentioned the mechanisms, reduction in ammonia through LOLA by inducing the urea cycle, improving the muscle mass and inflammation. He showed extensively several trials of L-ornithine L-aspartate for treatment of minimal and covert hepatic encephalopathy and overt hepatic encephalopathy. Ultimately, it was the bottom line message was that LOLA is a treatment adjunct in a patient with hepatic encephalopathy, and it can be used in patients who are refractory and not improving on routine therapies such as lactulose and rifaximin. It is not superior to either one of them and can be used as an adjunct for treatment of refractory or progressive hepatic encephalopathy. Professor Elliott, who's a professor from Michigan, discussed about the preventive aspects, the use of lactulose, the post-discharge care of patients with hepatic encephalopathy. He elegantly discussed how digital tools, artificial intelligence, text-based messages can actually prevent the recurrence of hepatic encephalopathy, doing early treatment, early diagnosis, post-discharge. He discussed how simple mobile-based AI tools can actually find out the efficacy of lactulose given to them through Bristol scale assessment, and he discussed role of nutrition, adequate protein intake at least 1 gram per kg in patients with cirrhosis and encephalopathy to improve the muscle mass, because the muscle mass has been clearly shown to be associated with occurrence of hepatic encephalopathy. So lastly, friends, I would like to mention that this international session was so engaging. It incited lot of discussions between participants, delegates, faculty members, which led to the lot of clarity as to when to use ammonia as a biomarker in hospitalized patients with cirrhosis, how to care the patients when they are discharged from the hospital using AI tools, text-based messages, automated use of technology to prevent post-discharge recurrences of hepatic encephalopathy, when to use LOLA in patients with cirrhosis, and what is the role of cognitive testing for minimal hepatic encephalopathy, because it is an important predictor of progression to overt encephalopathy, falls, poor quality of life, fatigue, and social life in patients with cirrhosis. And by doing certain assessments which are quick app-based applications, we can diagnose and treat these patients with lactulose and prevent the recurrences, hospitalizations, falls, and accidents. Thank you very much.